This is very exciting for me because this is something I've been doing, oral microbiome testing, functional dentistry, all of this for quite a long time. And it's been quite a while until I've been able to create a course and to try and tell people what I do, hoping that maybe you guys might take bits, you might tell me some things that you do yourselves. And, I think it's a new era of dentistry. So I'm just going to go through the agenda. We've got a lot going on. So I didn't think we needed coffee breaks, but apparently people get tired, and I got too excited, and I was like, everyone, all they want to do is talk about the oral microbiome, but we've added some coffee breaks for you guys too. So the first up is going to just be me. I'm going to be talking about what the oral microbiome is, and we're also going to go through the mouth-body connections. And then we're going to be have Jo Gamble, who is a phenomenal functional medicine practitioner who also works at our clinic. And she's going to be talking about the interconnection between functional medicine and functional dentistry. And then we're going to have a nice lunch break. No, we're not. I lie. Then we're going to talk about saliva. So then we're going to be talking about saliva, all the ways that you can test saliva, what you can find in the saliva, and how that can maybe enhance the way that you treat your patients. Then we're going to have lunch. Then we're going to be joined by Dr. James Kinross, who is a phenomenal gastroenterologist and colorectal surgeon, also the author of a book called Dark Matter, which I think was one of the best-selling books. And he really was one of the biggest... his book really changed the way that I saw the microbiome, and really was one of the things that started my journey. So when I reached out to him and he actually said yes, that was a bit of like an exciting moment for me. So hopefully you guys will enjoy his talk. He's actually in surgery right now, and he's coming straight after from hospital to come and speak. And then you're going to have me again, and we're going to be talking about how you can test the oral microbiome and certain things that you can recommend to your patients, or certain treatments that you could try out to actually improve your patients' oral microbiomes and therefore improve their treatment outcomes as well. And then that's kind of it, really. So a little bit about me. I don't know if anyone knows much about me. I'm a dentist. I graduated from Barts in London, and I have a postgrad diploma from in periodontology as well. I've been shortlisted for Forbes Under 30. I'm also a topical team member for NASA. So what we're doing with NASA is we're actually creating guidelines for astronauts. As you guys will kind of understand by the end of today, I really like saliva, and I really do a lot of testing with it. And so what NASA and the European Space Agency has kind of employed me to do is join their team and to look at how we can test the astronaut saliva to basically predict risk of certain diseases, and then actually modify their saliva and their microbiomes during flight to reduce their risk of having problems whilst they're in flight. We now understand that zero gravity conditions actually escalates a lot of your oral diseases. So we need to be even more, overcautious with these types of patients. And I'm also co-founder of the Health Society. So you're going to see a lot of people today who are helping out, and they're all from the Health Society. So we opened this last May. It's the first oral diagnostic center in Europe. We're trying to make dentistry understandable. And so what we're trying to do is convert your qualitative diagnostics into quantitative things. So numbers, colors, good, bad, things that patients can understand, instead of us saying, you've got a furcation level of 2 and you've got pocketing of 8 millimeters, and things that the patients don't understand those types of things. We also are trying to incorporate other parts of healthcare. So we have infusions, vitamin injections, we do blood tests, we have an infrared sauna, and we're very prevention focused. So what I want to really do with the clinic is we're really trying to push the idea that actually you can make money, you can run a business, but only based on prevention. And I think for a long time with dentistry, the kind of old, or conventional way was that you have to be doing lots and lots of restorative work. You need to be placing implants. You need to be doing 12 veneers. But actually, you can do a different type of dentistry and a different business model where you have patients coming more regularly with no treatments needed, but they're preventing their diseases, and you can still not go bust after a year. So we're really pushing on that. We have the first and only guided biofilm therapy lounges in the UK. So this is EMS, and we'll talk a little bit more about guided biofilm therapy later on. But it's not that we love the color pink. EMS chose that color. And so what we have is the Airflow Prophy Master, if anyone uses EMS, is fully integrated into the chair. And they designed the room to make it as comfortable and nice for the patient. We have a very lovely dental team, so we try and be as multidisciplinary as possible. We have a specialist orthodontist, so that's Dr. Ariane Sampson in the corner, and she does, in my opinion, a very different type of orthodontics. So I think it's important to note that, I'm talking all about the oral microbiome and saliva, but functional dentistry also includes other parts, and the other part of that is functional orthodontics. It's early interceptive orthodontics. It's looking at your airways and breathing. So these children who, have tongue thrusts, who have, difficulty swallowing, they're breathing with their mouths open, those are all big signs of issues. And if you don't sort those out when they're children, then those can actually become much bigger issues and actually have systemic consequences much later on as adults as well. We have a specialist periodontist as well, Pavan, somewhere here, specialist prosthodontist. We have an oral surgeon, and he does a lot of PRF, so platelet-rich fibrin, so he really tries to help restore and oxygenate the tissues afterwards, and also does cavitations as well. And then we also work with ENT, maxillofacial surgeons, and then we have a lovely team of hygienists as well, because again, prevention is our #1 thing. So ideally, in our opinion, it's better that the patients are seeing the hygienist the most and they're not seeing the dentist that much, because all they're doing is just preventing and improving their oral health. And then on the other side, the non-dental side, we also have a nutritionist who's also duly qualified as a dentist, so that's Mona, wherever she is, a functional medicine practitioner who's Joe Gamble, a myofunctional therapist. We also do acupuncture, kinesiology, and we also have physiotherapy as well. So it's a lot of work trying to combine all of those together. But the idea is that we're trying to put the mouth back into the body, and you cannot just treat the mouth and expect the rest of the body to improve, or the rest of the body and not the mouth and expect that to improve. So why are you all here? You're probably wondering why we've decided to just, all of a sudden out of the blue do this oral microbiome test kind of conference. And a lot of people have been asking me for years, how do I do oral microbiome testing? And I've been doing oral microbiome testing for a good couple of years. And to be completely frank, the oral microbiome tests that were on the market, they were good, but they were not user-friendly. It was literally just like levels of bacteria, do whatever you want to do with that. And so we are not trained as dental professionals to understand what that means. A lot of us are scared of trying different things out with our patients if we don't know if it's going to work. And we've always kind of been taught, like, this is how you do perio, so that's how you do it. And so this was a whole different type of dentistry. And because I didn't have the test that I could teach people to use and that was user-friendly and understandable, it was just really difficult for me to teach anyone, because I was like, okay, this is the oral microbiome, this is how you test it, but actually you can't analyze it. So, it's not really going to be very useful for you. And then how do I analyze the oral microbiome results? And I got loads of people trying to do oral microbiome tests and then being like, what do I do with these levels? I don't know what they mean. And then I would have to spend 2 hours trying to teach them, okay, well, if they have these 3 bacteria, then that might mean this, then you might want to add this, you might want to change that. And it wasn't scalable, it wasn't easy. Dentists could not actually just do an oral microbiome test for their patient without spending 3 hours on a treatment plan. What is the point in doing oral microbiome testing? There's still a few naysayers in the dental community who are kind of like, well, especially some periodontists are kind of like, well, the way that we've been doing perio has always been great, and so we don't need to change the way that we do things. But actually, when you look at it, periodontal disease is one of the most untreated diseases in the world. And actually, it's getting worse, and we're having more problems. So for sure, the work that periodontists do and perio's treatment is effective, but there are definitely people who are slipping through the cracks where we're not looking at everything else. We're not looking at the bacteria, the inflammation, their genetic mutations, and we're doing the same bog standard treatment for every single patient and expecting them to all respond in the same way. How about the host immune response? So now we understand that it's not just bacteria, but it's how the patient is responding to that bacteria. And that's, again, where the issues with the oral microbiome test were coming up. Because, okay, we see you have high levels of bad bacteria, but what does that mean? And so what was happening was I would have 2-3 patients, I would do the same oral microbiome test on them, and they would all come out with the same results, identical results. One would have terrible gum disease, and the other one was completely healthy and fine. And that's when we start realizing that actually within each bacteria, there are different strains. And some of those strains are very aggressive and some of them are not. So we actually need to be able to differentiate between those strains, but also how your body responds to bacteria, how inflammatory you are, how destructive your tissue is going to be. And so you need to have a deeper dive if you're ever going to be doing any oral microbiome testing, because otherwise you're actually going to not do it properly. You're not going to be diagnosing the right patients, or you're not going to be analyzing it correctly. So I went and I created a test. So this is THS Labs. This is our test. I'm obviously a little bit biased. It's taken me over a year to build this. And in my opinion, it, for me, kind of ticks all the boxes that I would need in a test. And I hope it ticks all the boxes for you guys too. So it's the first ever saliva test that analyzes your saliva for bacteria and genetic mutations. And it's looking at your host immune response. It's looking at how aggressive the bacteria in your mouth is. And it also creates personalized treatment reports. So we've built an algorithm which is able to predict the risk of certain diseases, so like gum disease, decay, and put those patients in those risk categories. And then based on that, also give them treatment recommendations. So which foods they should have, or what supplements or mouthwash or toothpaste or antibiotics that they should have based on the bacteria that they have in their mouth, and also how their body is responding to that bacteria as well. So where it all began for me, so I really got into the whole saliva testing oral microbiome space in June 2020. And that was right during COVID-19, the pandemic. And so I'm sure you all remember when the clinics were all closed, and the government basically said that dentistry was not useful. We didn't need to be open, and only key workers were able to work. So we were not seen as being key workers for 3 to 4 months or so. So that kind of annoyed me, because I was like, well, I think we do a lot more than just, fillings. And so I went and did a lot of research, and I wrote a paper which was the first in the world to connect COVID to oral health. So what I predicted was that poor oral health would increase your risk of COVID complications. And the reason for that was because it's the same inflammatory pathway. So COVID-19, it ignites a cytokine storm, so a really strong release of inflammatory markers. And as you guys will see throughout these lectures, you'll see that periodontal disease does exactly the same thing. So it's, again, lots and lots of inflammation. And so when you have both of those inflammations together, it's just adding petrol to the fire. And there's just lots of inflammation going on. Also, on top of that, it's bacteria. So, at the end of the day, periodontal disease, in my opinion, is a bacterial infection. We just don't treat it that way. But actually, it's high levels of bad bacteria in your mouth which are causing disease. And on a normal day-to-day basis, that might not cause any problems. But when you have COVID and you're immunocompromised and you're really, really sick and you've got this virus, then your body is in a very prime state to actually have a bacterial superinfection. So actually, when you look at the research, most patients did not die from the virus itself. They died from bacterial superinfections. And then when you look at their actual broncho lavages and their lungs, you could actually see oral bacteria was found in a lot of those patients in their autopsies. So I wrote this paper. It did well. It was the first one. It helped to actually reopen dental practices. So it was picked up by the World Health Organization, and they said, oh, wait, so the mouth is important. So the mouth is connected to the rest of the body, and maybe we should reopen dental practices. So got reopened, and I was approached by a few universities to do some research. And the issue is that we wanted to look at the mouths of COVID sufferers, but we couldn't because they had COVID, and so we weren't allowed to. So what we could do instead was collect their saliva. So we got nurses to collect their saliva, and then we were able to get this beautiful snapshot of what was going on in that patient's mouth at that moment in time. And that's where I was like, this is crazy. Why don't we do this on our patients? You can see so much. And it's like you go to the doctor and you get a blood test. Why don't we go to the dentist and get a saliva test? So what we found from the research was that patients with gum disease were 9 times more likely to suffer from COVID-19 complications. And this really, really opened my eyes to, let's do saliva testing. Let's make this a more commercially available product. And that was, the beginning of this, I guess. So we're going to start with the basics. So what is the oral microbiome? So it was discovered by Anthony van Leeuwenhoek in 1683. And he was a bit of a strange guy. So he just didn't brush his teeth for about a couple of days. And he had this white film on his teeth. So he scraped it off and he put it underneath his homemade microscope. And he actually drew the first ever bacteria. So you can see here, these are the first ever drawings. That's strep mutans. And so he realized that actually there's bacteria in your mouth and there's a microbiome. Fast forward a good couple of centuries, and we now understand that there are 700 different species of bacteria in the microbiome. This makes the oral microbiome the second largest and most diverse microbiome after the gut. So everyone gets really excited about the gut microbiome. We're all doing probiotics and all of these things, but actually the second largest one has no attention to it whatsoever. And people don't really understand that actually your oral microbiome is directly feeding your gut microbiome as well. So overall, it's 2 billion bacteria and 700 different species. And what's very unique about the oral microbiome is it's very heterogeneous. So what that means is within the same mouth, you have lots of different environments of bacteria. So if you think about the bacteria that might be hiding under your gums, or on your tongue, or at the back of your throat, or on your teeth, they're very, very different environments, and therefore you're gonna have different bacteria growing. So on top of that, if you look there at the Chinese buffet service, that is meant to be your saliva. And so your saliva basically travels around and it provides all the food, and the bacteria in all of their different environments will kind of pick up what proteins, what food they want, and that's what keeps them alive. So if you have no saliva, then these bacteria aren't able to grow. And when bacteria don't have the environment that they need, that's when they start to go pathogenic and start to cause disease. So this is where we see that xerostomia is definitely causing a lot of problems. And then on top of that, we like to add even more things into the mouth. So every single time we place a veneer, we put dentures, braces, grills, I don't know if any of you do that here, anything that you put into the mouth, you're adding another ecological niche into the microbiome and another surface for bacteria to grow. Now on top of that, the teeth are the only non-shedding surfaces in the whole body. So what that means is that if you don't brush your teeth, then no one else is brushing them for you. It's going to stay there, and that bacteria is just going to keep on growing and growing and growing. Whereas if you never showered, or you didn't clean your hair or anything like that, your skin sheds. So you kind of, in a way, self-wash, whereas the teeth do not have that. So that's why mechanical removal, and we all know that, but mechanical removal of that plaque and biofilm is super important, because otherwise that bacteria just stays there and grows. So in a healthy environment, you have this beautiful balance of good and bad bacteria. We all have bad bacteria in our mouths. It's normal. You can't kill it. And usually that bad bacteria is not really doing anything. And so you've got this really nice balance, and it's what we call symbiosis. But then what happens in disease is you get a shift into dysbiosis. And things that can shift that microbiome into dysbiosis and increase the number of bad bacteria are things like your diet. So if your patient's having a high sugar or high carbohydrate diet, then that's going to be shifting it, because there's more sugar, there's more acid being released, and so different bacteria are starting to grow. Poor oral hygiene, and this again goes into that, if you're not having any mechanical removal and that bacteria is growing and it's not shedding, then you're going to have lots and lots of different bacteria growing, and they're going to start changing as well. Antibiotics, so sometimes obviously they're necessary, but they're also a bit of an atomic bomb, and they kind of just deplete everything in the microbiome. So in my opinion, it's really important that if a patient does have to take antibiotics, they know how to re-nourish their oral microbiome afterwards to make sure that the right good bacteria grow again, because otherwise it's kind of a desert, and whatever can grow grows, and often it's not great things that grow. Medications, so there's a lot of medications that actually will make your saliva more acidic, or will actually change the oral microbiome as well. Reduce saliva, and this is one of the biggest ones. So xerostomia, as we all know, increases your risk of decay and gum disease. So there are certain diseases which also will shift that oral microbiome into dysbiosis. And having done this test more and more, and I've been using this for quite a long time now, I'm starting to see that there are certain diseases where patients just have higher levels of certain bacteria, or they have higher levels of virulence factors which are being released by their bacteria. Genetics. So this is something which I think we've all been taught that, when a patient's like, oh yeah, it's in my genes that I don't have good teeth, it's not my fault, and we all roll our eyes and we're like, yeah, okay, fine. But actually, so there are times where there are genetic mutations which increase your patient's risk of decay and gum disease and inflammation, and we're going to go through those later. Smoking, we all know that that doesn't help the oral microbiome. And so is all bacteria or biofilm bad? And I think really for us to understand what is good and what is bad, you have to go back into the history. So like we said, 1683, bacteria was discovered. We found out that there was actually bacteria in our mouths. In 1930, we had the non-specific plaque hypothesis. And this was the idea that all bacteria causes disease. This is where things like Listerine, where you had these really antimicrobial mouthwashes, and their kind of advertising was like, kills all bugs, kills all the bacteria. And so a lot of patients still to this day think that bacteria is bad and we have to kill everything. But then in 1976, there was something called the specific plaque hypothesis. And this was the idea that it's actually only certain bacteria that causes disease. And so, for example, with decay, it's certain bacteria like strep mutans that causes that disease, but it's not all bacteria. And then in 1994 came the ecological plaque hypothesis. And this was the idea that it's not just the bacteria that causes disease, but it's how that patient's body is responding to that bacteria. So this is the host immune response coming in. And then last but not least was 1998, the complex theory. And this was created by Sokransky. And Sokransky thought, actually, it's not as dichotomous as good and bad bacteria, but it's varying levels of bacteria. So he created a pyramid. And at the top of the pyramid, you have your really, really big, bad, horrible ones. So your red complex pathogens. And so these are things like Porphyromonas gingivalis, Treponema denticula, Tannerella forsythia. So these are the really, really, really bad ones that we don't want. And then as you go down the pyramid, you can see that they're a little bit better. The green ones are actually good. They're not bad at all. And so he decided it's more of a sliding scale as opposed to good and bad. So let me see if these work. Yay. So let's go back into the body, and we're actually going to start looking at how a biofilm is created. So we go onto our tooth surface, and this is how the biofilm starts. So you have what you call your acquired pellicle formation. So these are your complex carbohydrates, which will form just on the surface of the tooth, and this happens within seconds of a patient brushing their teeth or having their hygiene. So you've got these complex carbohydrates that are being given from the saliva. They sit on the enamel. And they basically have these little dendritic hands which can grab onto bacteria. I like to think of it as Velcro. And so that Velcro then sticks onto your first bacteria. So these are your pioneering bacteria, or what we call your microcolony. So these are your early adopters, or your early bacteria. And then bacteria like to party. So when there's some bacteria, more bacteria will start to form, and it'll keep on growing and growing. And this is where it goes from a microcolony into a biofilm. And then what happens is that you start to get maturation. And what that means is that if you think about the bacteria, which is just here, that bacteria is now not able to breathe anymore. So it has no oxygen. And so it actually starts to mature and change. And those bacteria start to become anaerobic. And when bacteria really starts to become anaerobic, that's where you start seeing disease starting to form. Because generally, overall, anaerobic bacteria is not very great for the oral microbiome. And then as you go up, you've got different levels and types of bacteria. And then last but not least, you have the dispersal of bacteria. So imagine you have this really, really thick biofilm. Obviously, if a patient's lip moves, something happens, little pieces of those bacteria are actually being dispersed, and they're actually able to leave the mouth, and either they can be swallowed via the saliva, they can travel through the blood elsewhere, or you can breathe them, and they can actually dislodge into the lungs as well. And this is where that COVID complication was found. So why is the oral microbiome so important? And we're going to split it up into two. So I'm sure you guys all know that there is increased risk of decay and also increased risk of periodontal disease. So these are the classics that we do kind of know at this point. But actually, what we also understand is that if you have an imbalanced oral microbiome, you also have something called low-grade chronic inflammation. And you also have leaky gums. Has everyone heard of leaky gut syndrome before? All right, so everyone pretty much knows leaky gut syndrome. Has everyone heard of leaky gum syndrome? No, it's the same thing. So it's basically, if you think of your gums as a mesh, then what happens when you have an imbalanced oral microbiome is those gaps start to actually increase, and they have larger squares or larger holes. And so more things can go in and out. So if you think of your gums as this barrier made out of mesh, that mesh becomes larger with larger holes, and bigger things can go in and out and cause problems. But really, I think the biggest takeaway is low-grade chronic inflammation. And low-grade chronic inflammation, the definition is a systemic status of chronic subclinical production of inflammatory factors. And this condition represents a risk factor for many chronic diseases. So this is the idea that you have inflammation from your mouth, and it's just constantly firing and traveling through to the rest of the body. And if you think about it, it's essentially, I mean, it's gum disease, it's gingivitis, but it's so chronic and so sub-level that most of the time we don't even realize or understand that it could be contributing to elsewhere in the body. But if you think about, and this is how I always say it to patients, I say if you had an infected toe, okay, and it was a bit yellow and it was just bleeding all the time, every time you took your sock off there was blood there, they would probably go and do something about that, right? But they would also understand that that infection and that inflammation is probably not good for the rest of their body. But for some reason, when it's in their mouth, they don't think the same way. But it's exactly the same thing. So patients with periodontal disease have an increased level of their interleukins. So their interleukin 1, 2, 6, 8, and 10. Their tumor necrosis factor, their prostaglandin E2, their lipopolysaccharides, and their CRP. So essentially lots and lots of inflammatory markers and lots of inflammation being released. And this is where we see that link with your other inflammatory conditions in the rest of your body. So for example, your patient suffering from rheumatoid arthritis and they have periodontal disease, that inflammation from their mouth is contributing to their inflammation elsewhere in the rest of the body. And we're going to go through some case studies later on as well. So how is the oral microbiome actually connected to the rest of the body? So there are 3 different mechanisms. The first one is translocation of bacteria. And this is the idea that you have bacteria in your mouth and it's being either breathed or you're actually swallowing it and it's going straight down into the stomach, or it's going directly into your blood vessels and traveling elsewhere. And the one that everyone is always taught at dental school is infective endocarditis. So that's literally bacteria from your mouth traveling down to a faulty heart valve and causing death in some cases. But actually we understand that this is happening at a lower level, maybe not death, but it's happening constantly with other issues and diseases too. So now we have a friend actually who she just had a knee surgery and she's been told she can't have a hygiene for up to a year because of the translocation of bacteria from her mouth, which could infect her knee. So even surgeons are starting to understand that, but a lot of the time dental professionals don't. But it's happening on a daily basis. The second mechanism is the idea of metastatic injury. And this is the idea that you have your blood vessels and you've got this bacteria traveling through and it releases these virulence factors and toxic enzymes, and they're actually able to harm the blood vessels. And so what that means is it will actually stop your blood vessels from vasoconstricting and dilating. And this is where we see issues with limited blood flow to other parts of the body. And also, obviously, with the gums, that's why they always bleed as well, a lot more. And then last but not least, your third mechanism is low-grade chronic inflammation, which hopefully you guys know by now. And this is the one that I think is really, really, really important. So that's just your inflammation traveling elsewhere. So we're going to go through a couple of different mouth-body connections, some of the oral systemic links that are coming out, more and more research is coming out about them. So our first one is going to be Alzheimer's. This is the one that most of my patients are worried about or asking about recently. So these are the studies. So there was one study, and it was a retrospective cohort study, 18,672 citizens. And I always feel like I have to say the number of citizens because all the time they're like, oh, it can't be real. So they had nearly 19,000 citizens, and they found that having gum disease for more than 10 years increased the risk of Alzheimer's by 70%. And if you still don't believe me, there was another study by Beidoun, and it was a 26-year follow-up of 6,000 participants, so it's quite a long follow-up. And they again found a strong correlation between an oral bacteria called Porphyromonas gingivalis and Alzheimer's occurrence. And Porphyromonas gingivalis has been something that we've really worked on in the test to try and make sure that that's very, very strong. And you'll see that through all of these mouth-body connections, Porphyromonas gingivalis is probably one of the main culprits of that connection. So what they found is that there was actually high levels of Porphyromonas gingivalis in the brain tissue and spinal fluid and saliva of Alzheimer's patients. And Porphyromonas gingivalis is it's an oral bacteria. It's really predominantly only found in the mouth, and it can release these toxic enzymes called gingipains. And these toxic enzymes are able to travel from the mouth elsewhere to the rest of the body. We're now understanding that these gingipains are what causes collagen destruction. So patients who have things like Ehlers-Danlos syndrome or hypermobility actually is coming from gingipains and their Porphyromonas gingivalis. But also in this case, those gingipains are traveling from the mouth up to the brain. They are very, very small, so they're able to cross the blood-brain barrier, and they were found in 96% of patients who were suffering from Alzheimer's. So these gingipains were found in there, and compared to normal healthy patients who did not have any gingipains in their cerebrospinal fluid. They also have now found that Porphyromonas gingivalis increases the production of your amyloid beta. And amyloid beta is what makes your amyloid plaques. And we now understand that amyloid plaques are also something to do with neurons in the brain and impacting your Alzheimer's as well. And this was one that I just recently read, which I thought was really fascinating. So we kind of now understand that gum disease, Porphyromonas gingivalis, is definitely linked to the occurrence and incidence of Alzheimer's. But then what this study also showed was that there was a connection between periodontal infection and cognitive decline. So they had 60 patients, it's much smaller, and they assessed the dental health of these 60 patients. So they'd all been diagnosed with very early stage Alzheimer's. And they found that those with Alzheimer's, after 6 months, had a much faster rate of decline than those who did not have periodontal disease. So even if you have a patient who has Alzheimer's, you're like, oh, it's too late, sorry, I didn't get rid of your Porphyromonas gingivalis. That is not the case at all. You can actually still at that point try and make sure that their periodontal disease is completely stabilized and try and remove those bacteria which are clearly contributing to their Alzheimer's and their cognitive decline as well. By the way, if anyone ever has questions, please let me know. And then the next up is heart disease. So we've got a 25% increased risk of heart disease and also 20% increased risk of your high blood pressure as well. So again, I like my research, so we're going to go through a few more studies. So going back to those 3 mechanisms I was telling you about, which connect the mouth to the rest of the body. So mechanism number 2, which was all about the blood vessels and the issue of vasodilation and vasoconstriction. This is basically the connection with cardiovascular disease. So what they've found is that patients with periodontal disease have impaired vasodilation. So that means the blood vessels are not able to dilate as they should, which means that blood is not able to travel to the heart, but also that's the link with the high blood pressure as well. They also found that patients with periodontal disease also had very stiff arteries, and that also contributes to that vasodilation and vasoconstriction issue as well. And this is kind of just a little graph which shows that. So you've got your chronic gum inflammation. It's causing lots and lots of inflammatory markers to be released, and that's traveling elsewhere to the rest of the body. And that is then causing atherogenesis, which is basically production of atheromas, and that's what are those plaques that impact your heart. And then also your vasodilation and your vasoconstriction issues as well. And then the next one is one that I love is maybe not the right word to use, but something I'm really, really fascinated by and interested by. And it's the idea of autoimmune disease. It's these chronic inflammatory conditions. And so what they found with just like the umbrella term of autoimmune diseases is that there's an increased prevalence of periodontal disease in patients who have autoimmune disease. And in particular, something that I'm really focusing on is rheumatoid arthritis. And the reason for that is because I've seen such phenomenal results in a patient's general health just by treating their gums. And rheumatoid arthritis is quite, it's very debilitating at its worst. And that really started my journey. Was I had a patient, rheumatoid arthritis, and we treated her perio, and then her rheumatoid arthritis got better. And I was like, whoa, that's crazy. Like that's happening, you know, and that's where it all really started as well for me. So they found rheumatoid factor detected in the gums of patients who had periodontal disease and rheumatoid arthritis as well. And it's self-perpetuating, it's bidirectional. So the worse your gum disease is, the worse your rheumatoid arthritis is. The worse your rheumatoid arthritis is, the worse your gum disease will be. So if you improve one, then the other one will improve too. So it's kind of like diabetes essentially, basically, as well. And the next is male infertility. And so we're going to split it up into men and women. So for men's infertility, what they found, so there's been quite a lot of research into this, they found that they had a huge group of infertile or subfertile men. And they split the group up into 2. And before that, they actually tested all of their mouths. And they found actually that over 90% of those men had some sort of oral disease, be it gum disease, be it bacteria, decay, infection, something was going on basically. They split the group into 2, and they treated half the group with the correct treatment, improved their oral disease, whatever it was. And after 8 months, they followed up, and they found that there was a 70% pregnancy success in those patients who had had their gums or their teeth sorted, compared to it was a 20% pregnancy success rate with those who had not had any treatment done. So obviously it's very multifactorial, but that is also a massive shift. And I think also with fertility, a lot of the time there's a lot of focus on the woman's fertility, but actually men need to just be as involved in that too, and this shows that as well. They also found a positive association with your periodontal pockets, so your gum disease, and sperm submotility. So the sperm of these patients was not as mobile, it wasn't as active as those without periodontal disease. And this one always gets the men brushing. 2.85 times more likely to have erectile dysfunction if you have periodontal disease as well. Now on to our ladies. So a woman with periodontal disease, there's been a lot of research to show that there's a prevention of ovulation. So because of that increase in inflammatory markers, particularly interleukins, it's actually inhibiting some of the hormones that are needed for conception. And they found that patients who had periodontal disease, it took them 2 months longer to conceive than those who didn't have gum disease. Now, on top of that, once the woman's pregnant, great, but actually she's still not out of the woods. We all know about pregnancy gingivitis. We all know that that's, a big issue. But actually, not only are the gums having a problem, but actually it can really impact the development of the child as well. So they're finding metabolic waste products from oral bacteria in the placenta of patients who have periodontal disease. And patients who have periodontal disease have a much higher risk of preeclampsia, low birth weight, and preterm birth as well. So for me, if ever I have a patient who has periodontal disease, who's pregnant, I'm making sure they come every 3 months for a hygiene. I don't care how well they brush. They're coming right before. And then what I also do is right before they're giving birth, maybe a couple of weeks before they come, because I also know that probably once they have a baby, the last thing they're thinking about is their gums, and they're going to come again in a year. So just right before they give birth, and then you can see them straight as soon as you can after as well. And if you didn't believe me still about the preterm birth and low birth weight, this was a really cool study that was done in Malawi. There was a very large study, 10,000 women. Malawi has the highest rate of preterm births in the world, just under 20%, so 19.3% of women in Malawi. And preterm birth and low birth weight is a very big issue, particularly if you do not have the ability to take care of those women and those babies. It's very expensive. And so Malawi, it became a bit of a national crisis for them. And so weirdly, Wrigley's, the chewing gum company, was like, I've got just the answer for you guys. So they came over to Malawi and they had these 10,000 women. They split them up into two. 5,000 of the women were given a toothbrush, toothpaste, and sugar-free chewing gum, and the other 5,000 were left to their own devices, whatever they normally do. And what they found was there was a 24% reduction in preterm births in those women who chewed the sugar-free xylitol gum and brushed their teeth compared to those who didn't. So again, something so cheap, so easy, having that much of an improvement is massive. And this is something I actually very recently added because I'm getting more and more women who are perimenopausal, who have endometriosis, and I think I'm kind of in a bit of a bubble where I attract patients who don't really know what's going on and they have always some sort of gum issue, and so they come to me. And so I thought it would be interesting for you guys to see what I'm finding as well. So one thing I see a lot of in patients who are perimenopausal and also with endometriosis is unexplained, really, their gums are bleeding a lot. So had a patient actually relatively recently, she's 21, 22 years old. Her oral hygiene was pretty good, no pocketing, everything was fine. And she was coming every 2 to 3 months for a hygiene. And she was like, I don't know what to do anymore. My gums bleed all the time. And so we actually sent out, I said, maybe you should get a full, go to your doctor. There's something not right here. She went, and it turns out that she was diagnosed with, she's 21, but she's just been diagnosed as menopausal, and she's also got endometriosis as well. Since that, she has improved her gums have improved because she's now having treatment for that. So it's not easy to necessarily, I'm not saying anytime you see someone with bleeding gums, you should be like, I think you should go and check that out. You have endometriosis. But sometimes bleeding gums, if that patient doesn't have gum disease, it's the body screaming and crying out for something else. And you should definitely not just blame them for oral hygiene when you know that their hygiene is good. So they found that women with endometriosis had a 57% increased risk of developing gingivitis and periodontitis. And it was associated to do with something with the immune dysregulation and high levels of inflammation as well. And on to the one that we probably all know, which is diabetes. This is the one that everyone's kind of taught. But I thought it's nice to maybe have some more updated stats about it too. So patients with periodontal disease are 53% more likely to develop diabetes, and patients with diabetes are 34% more likely to develop periodontal disease. So that's where the bidirectional relationship comes up. They also found that uncontrolled diabetes increases the risk of infection and reduces your wound healing as well. So you need to be extra careful with these patients. And what they also found was that periodontal treatment reduces your blood glucose levels by 0.5%. So your HbA1c as well. So this is your, and that is actually a huge reduction for an HbA1c level. So this is not, people who got the I don't know what's called blood glucose levels here. It's not that. It's actually what is your bound glucose over 3 months. And a reduction of 0.5% is essentially the equivalent of someone really changing their diet for quite a long time. So just by doing that, you can already improve your patient's diabetes as well. And again, it's bidirectional, so we know that if you treat the diabetes, the gums will get better. If you treat the gums, the diabetes will get better too. And on to our last but not least, before you guys get bored of my voice, is the oral gut axis. And so as I kind of touched on this earlier, the idea that your mouth is connected to your gut, that actually a lot of people say that the oral microbiome is an extension of the gut microbiome. I'd like to argue the gut microbiome is an extension of the oral microbiome. It's first, I think. Basically the idea that you're swallowing constantly, and a lot of bacteria in your mouth is acid resistant, so it can actually come in and stay in the gut and cause problems. And so we kind of know this. I put this up because we are all taught, how can you find a patient who has a gastrointestinal disease? Often it's in their mouth first, right? So we're all taught about Crohn's disease, ulcerative colitis, celiacs, orofacial granulomatosis, all of these things that we're taught at university, but no one ever really talks about the connection between the oral and gut microbiome and why we're seeing those issues in the mouth first. And the reason why is because actually the cell turnover in the mouth is much higher than in the gut. So if there's issues going on in the gut, the patient won't have symptoms for at least like a month or two, whereas they might have symptoms in the mouth within a couple of weeks because those cells are turning over so quickly, and a lot of the cells are quite similar to the ones in the gut as well. So this came out with Apple News. It was in 2024, so very, very recently. I was very excited to see this because I think this was one of the first times that mainstream news was picking up the connection between the mouth and the rest of the body. So there's been an unexplained rise in colon cancer. We don't really know why. It's often actually in young, healthy people, never smoked, they don't drink, everything's kind of perfect about them. And so there's been a lot of research into this, and Dr. James Kinross, who's coming this afternoon, is going to be bringing this in a lot more because this is actually where he's really interested in. So this new research has shown that there's a specific oral bacterium, your Fusobacterium nucleatum, which is linked to colon cancer growth and progression. So they're finding that patients who have F. nucleatum in their mouth and also in their colon as well, have more aggressive cancers than those patients with colon cancer who don't have F. nucleatum. They also found that F. nucleatum was found in more than 50% of colorectal cancer tumors compared to healthy people who don't have any of that in their colons as well. So I'm also working with another person in America. He's created an antibiotic which only kills Fusobacterium nucleatum. So what they're doing now, the trial, is they're going to patients who have colorectal cancer. They're giving them that antibiotic to get rid of their F. nucleatum to see whether or not that would reduce the progression and activity of their colorectal cancer as well. So again, you're seeing all the connections coming up and how we can treat something here and that can slow down something elsewhere as well. And gut dysbiosis equals oral dysbiosis. So we now understand that patients with gum disease have a much more imbalanced gut microbiome than healthy patients. And on top of that, a professional hygiene treatment, so just a nice little hygiene, has a significant improvement in the gut microbiome. So it reduces the levels of bad bacteria in your gut. On top of that, patients who have periodontal disease have much higher levels of your bad bacteria in their gut compared to other patients. And that's why at our clinic we work with nutritionists, we have a functional medicine practitioner. To be honest with you, if you could do oral and gut microbiome testing at the same time, that's the beautiful, that's the gold standard, that's fantastic. And the reason why is there's no point in a patient fixing their gut microbiome if their oral microbiome is an absolute mess, because you're just going to be feeding all of that bacteria again. But also if you're fixing your oral microbiome and your gut microbiome is a mess, it's also going to be directly linked there as well. So that's if you really want to get deeper into it as well. So that's me finished for today. Well, not today. You're gonna have more from me later. But actually, I really want to introduce to you guys Jo Gamble. She is the first ever functional medicine practitioner in the UK. We started working together a couple of years ago, and she started sending over some patients to me, and you'll see the type of work that she does. She send over these patients, and I would do their oral microbiome. I was fixing, most of them had something wrong with them. Most of them had some sort of gum disease, infections, etc. And what we found was that when we worked together, you're kind of killing two birds with one stone. It was easier for me to treat their periodontal disease, but also she was able to manage their inflammation and their issues as well. And that's where we had this idea that actually we should all be working together. So Jo actually joins us now at the Health Society a couple of days a month, and she sees a lot of patients and she tries to link it back to dentistry as well. So I will leave it to you.
Thank you. Okay, honey.